in India. So everybody can join in on time, but I'm sure we'll at some point we'll have more than 200 viewers. So
Good evening, all. On behalf of Dr. Sanket Mehta and Specialty Surgical Oncology Hospital and Research Center, I thank our international speaker, Professor Guido Torzilli, our national experts, and participants who have logged in today for the first of the services, Masterclass in Surgical Oncology. Now I request Dr. Sanket Mehta, who is Senior Consultant Surgical Oncologist, Specialty Surgical Oncology Hospital and Research Center, to give the introductory talk. Over to you, Dr. Sanket.
Good evening, everyone. It is my great pleasure to host the first in the series of Masterclass events by Specialty Surgical Oncology group today. At the outset, I would like to thank Medtronic for sponsoring this event. And it gives me immense pleasure to invite Dr. Guido Torzilli to this event today. Good evening, Dr. Torzilli.
Good evening to everyone. Thank you very much.
It is such an honor and privilege to have you here today. And I would also like to thank all the faculty members who have joined in, Dr. Saklani, Dr. Ganesh Nagarajan, Dr. Praveen Kamar, and Dinesh Choria are with us today. Dr. Torzilli, I'm going to take a few minutes to give a quick introduction so that our audience can connect with you and realize why you are such an expert in the domain of hepatobiliary surgery. So Dr. Torzilli, as we all know, is from Milan, and he is known for his clinical and scientific activities in the field of precision surgery for malignant liver tumors. He has done his post-graduation in general surgery from the University of Milan. And at some point, he has got interested in ultrasonography of the liver, and he migrated to Japan, to the University of Tokyo as a fellow for the Japanese Foundation for Promotion of Cancer Research. Dr. Torzilli, can you briefly tell us at what point in time did you get interested in ultrasonography and why Tokyo?
I started getting interested in ultrasound by chance when I was a student. And I wanted to learn something more than just surgery. And one of my senior residents was doing ultrasound, and I follow him. And then I enter in the dynamics of the use of the ultrasound, especially, of course, for the liver. Then I get passionate with the treatment of liver tumor during my residency.
Yeah.
I learned the ablation technique. I have been the pupil of the guy that has invented the ethanol injection and ablation. It was Livraghi, and he was a real master for me in ultrasound. Mm-hmm. And after he suggested me, because I wanted to be a surgeon, not a radiologist, to follow a guy that he was every time in the world challenged to have a debate, and the guy was Makuchi. Then he introduced me to Makuchi. Then I traveled to Japan. He liked me because I was one of the first Western doctors, young enough to be a clean mind, but not infected by the Western approach in his perspective. And on the other hand, I was already knowledge about the ultrasound. This was surprising him because he never met a young surgeon from the West expert in ultrasound. As you know, Makuchi was the one that introduced the intraoperative ultrasonography. And then he offered me the fellowship, and then after he gave me the position and the PhD. So I built my career upon his teaching.
So how long were you in Tokyo, Dr. Torzilli?
The entire duration was 4 years, but I spent some time back in Italy due to family and work reason. And at the end, once I was anyway employed, I received an offer to come back to Italy from Mazzaferro. I accepted, but at the end, when I came back, I didn't go to Mazzaferro. I ran my career. And at the end, it was a good choice.
Yeah, and it must you must be really good at what you do, because you got a PhD and you were even an assistant professor in Tokyo. I'm sure that's not very easy to do it as a foreign national.
I guess I have been the only Western surgeon in the history of Tokyo University.
Okay, that's really amazing. And after coming back, you joined the Hospital of Lodi for 4 years before you joined Humanitas University Hospital and Research Center. That's right.
Yes. When I
Can
came back,
can you briefly chart out for us the last 20 years that you've been working in the hepatobiliary unit? You've done some such amazing work. Everybody is ready to celebrate.
I had the privilege to, when you come back in Italy, Italy was protective family power and the political power, and I had nothing of that. And for me, starting in a peripheral hospital was somehow a luckiness, because I could work without not under the visual control of the big bosses. And then I grew up. I had the chance to grow my pupil from just after graduation, and after 20 years, when my first staff just 2 weeks ago became autonomous and ran a program in another city in Italy, Daniele Del Fabbro.
Oh, he's left. Oh, okay.
He moved. Fantastic surgeon, and now I have the privilege to build my own team, and all the people that work with me are fellow of myself, and they can do the operation that I do.
Yeah, so you have developed such a wonderful team. During my stay out there, I had the privilege to work with everybody from your department, and I must acknowledge all of them: Matteo Cimino, Donadon, Luca Vigano, Daniel Del Fabbro, Fabio Procopio, and Angela Parmesano. I hope I've not got it wrong. Yeah. These were the ones that were there, and they were such wonderful people. They would help us with resource material, take us to coffee every day, and help in the nuances of intraoperative sound. It was really amazing. I mean, how did you manage to get such wonderful people and develop such a beautiful culture where everybody is so keen to impart knowledge? It's really amazing.
I think it was by chance, and I was lucky, I must say. And I am convinced that the people meet together when they have a good feeling each other. And you do not select the younger, you select the younger, but also they select you.
Okay.
And at the end, once during my traveling, I saw the team of Sung-Yu Lee.
Okay.
Just after I came back from Japan, I visited him just to see the living donor, and there was a meeting, and then I saw him building a team fantastic. He was managing simultaneously several operations, but he was not operating everything by himself. He had at least 6 persons that can do what he was doing. And then I thought that I would like to realize similar things in Italy, and I succeeded.
Wow, that's amazing. So we know that you are the editor of 2 books and a guest editor in numerous international journals. You co-authored or authored more than 300 papers in high impact factor journals and more than 60 book chapters. I mean, how do you manage to do all this while you are managing such a busy surgical unit? It's really amazing. It really inspires us.
Despite, I have 300 papers, and the leadership is important. Most of our papers are coming from my group. So I have around 60-70% is product of ourselves. Of course, others become, the name inserted in other studies run by a pathology or international because you share the database. But I like to say that we have our own track, and this is the main body of our scientific activity.
Yeah. So you've described several different innovative hepatectomies, with the help of your depth of knowledge of liver anatomy and ultrasound. Can you share us a little bit about, how you went about, what inspired you to conceptualize these procedures? From the standard 2-dimensional, was there any resistance while you were describing these procedures, which were not the standard, sectionectomies that have been described in the Western literature?
If you think about when you, the luckiness was to be trained in Japan, In Japan, I learned that you have to look at the liver from every angle that you could. It's not just a vertical approach. I learned the ultrasound, and then if you use the ultrasound, you can feed through. You are not scared of the organ and the anatomy. You can challenge the anatomy, challenge in a positive way, and then you have in reality an infinite number of solutions. Is the only organ, even is a solid organ, very complex, in which the combination of positioning of the tumor is infinite.
Yeah.
And then why you should provide only 8 kind of operation? You have the possibility to provide infinite number. I mean, I just describe 5, 6 new operation, but there could be the possibility to describe, infinite solution. And this is amazing. And just doing right hepatectomy, left hepatectomy, or whatever is, you are constraining the possibility that surgery provide to the patient to clean the tumor, to free from the tumor the organ.
Okay. Yeah. Thank you so much. So without further ado, I would like to request you to proceed with your presentation. Dr. Torzilli, we are all ears.
Thank you. Okay. I will share. I need the permission to share my video. Okay. Okay. So it's my pleasure to be here and to share my experience in liver surgery in this masterclass. And I thank Dr. Sanket Mehta, therefore, for this great invitation and the pleasure of dealing with all of you. It was asked to deal with ultrasound, parenchyma sparing, colorectal liver mets. Well, the novelty that parenchyma sparing is better than major hepatectomy probably is almost obvious. It provides more salvageability, and in terms of long-term survival is better either for survival and also for the disease control. Yes, from a multicentric study to collect a lot of patients, and then there are a lot of bias inside. And moreover, we are not acknowledged of the real homogeneity of the series and the approach. One of the things that is difficult for liver surgery is to categorize the procedure, because as I said, it's such a fantastic organ that you have so many alternatives that still the surgical attitude is an important factor that is often neglected in all the analysis. And this is the Brisbane classification of the operation. The lions of this classification are the vertical dissection, the major hepatectomy, and of course there are the limited resection, but apparently they look marginal. And in the fact, despite everyone is talking about parenchyma sparing, well, somehow they are talking about just the peripheral removal of tiny tumor, for whom the alternative, but for me is incredible, would have been a major hepatectomy. I would never imagine a major hepatectomy for a tumor like this. Indeed, the fact that is marginal is that although promoted, anyhow, it remains a significant rate of major hepatectomy in the major series. Then we should really believe that that's all. I was fascinated by the the idea that there is a sort of dark matter, like in the universe, that we cannot catch in the liver. And this dark matter should be recognized to imagine being able to operate a patient like the one that you see. The green lesions are the tumor, the others are cyst. And imagine to operate this patient in a parenchyma sparing modality. Let's see if this could have been suitable. First of all, I take profit of the paper of Pietro Maino, in which he was making the similitude between the tree and the liver. No? Think at the liver as thinking at a tree. Indeed, the liver is like two trees put together in opposition each other, because there is the portal tree. This is a cast from the web. There's a portal tree in red and the hepatic vein tree, and all of them looks like this, a real tree. And then if we take the image of the lesion of the liver with the lesion that I showed before, and we tilt that image and we compare with the liver, with the tree, and we put into the tree the exact number of lesions that has the patient, which are, and we consider the fruit, rotten fruit that we have to remove, then we have to imagine how can we remove all the rotten fruit without sacrificing the tree. And it's, of course, not reliable, an approach like the right hepatectomy or the left hepatectomy. Then the woodcutter technique, the woodcutter surgeon may not be effective for this solution. The woodcutter surgeon has tried to offer to this patient an alternative, splitting into two the operation, two-stage hepatectomy, or more recently, the ALPS. But this has not been the case of this patient, since in this patient, we would have had only 28% of future liver remnant, despite we would have anyhow accepted the R1, and we would have done we should have done two ablation. Then somehow the stage procedure are limited and cannot offer for such a complexity a solution. Those procedures that were devised to operate the patient that should have been unresectable, theoretically unresectable. To make resectable the unresectable, the stage procedure has been devised. The only alternatives looks, according to the woodcutter philosophy, to transplant the organ, or to cut the liver and the tree and put another tree. It seems interesting, promising, more than promising. There are several trials that are going on, and I'm sure it will succeed. We will have to redefine the border between resection and transplant, also for the colorectal liver mets. But around that, anyhow, there is something else, and the rationale for that is the concept of the anarchist anatomical resection. I named that because, especially now with the laparoscopic surgery, there is a big effort to show that it's possible, resuscitating the Takasaki technique with the Eiler approach to do very, sophisticated and, I may say, dangerous for those who are not expert attempt to do segmentectomy or whatever. But in reality, I am convinced, and in this sense, I am following a different path from my master, who was and who is the father of anatomical resection, the parenchyma sparing anatomical resection. I think that you just have to read the anatomy of the organ and take profit from that, considering that, like in a tree, use the ultrasound to disclose the area in which the lesion or the lesions are contained. Then once you have devised the area, once you get deep, you will for sure immediately find a major vessel, the peripheral aspect of a major vessel. And then, like in this case, just a few millimeters below, you see already the major branch of the hepatic vein. Then you follow the hepatic vein and you have the direction, and then you get deep and you follow your dissection and anatomically according to which to the path of transection that you have decided. And then most of the time you are doing a real anatomical, fully respectful, but à la demande resection. Here you see the middle hepatic vein, the branch is just here, and then we follow the branch, we expose the vein. Now, in this case, we have to resect the vein. This is the vein that has been resected. We continue our dissection and following also the Glisonian pedicle behind, and with the finger behind, we target our the point of to which we have to direct our transection. And then you see the green line is our dissection. The green line is our dissection. The yellow is the movement that you are with the other hand tilting the dissected, the area that you are going to remove. The finger of the left hand is here. And then you follow again the pedicles, and this is the path that you are following, a real vessel-guided resection. The pedicle, this is the portal bifurcation, this is the posterior, the anterior, and you achieve the right hepatic vein. You have cut the middle hepatic vein, and this is a tunnel. The formula for doing this operation, which is collecting the main principle of this kind of surgery, is, of course, you have to be familiar with the ultrasound because it discloses you the way to go. Then you have to challenge some other concept. This is the ultrasound that makes transparent the liver, and then from here you shift to here. And you follow, in reality, your own track to guarantee the clearance of all the tumor. The other aspect is you have to be a little bit courageous, but not foolish. I mean, R1 vascular, what that mean? Is there that a day I wake up and I decide to detach the tumor from the first patient casually? No, it was not like this. Of course, we were thinking that possibly there is a difference in exposing the tumor, and this could be also in between the liver parenchyma or in relation with the major vessel. Should this kind of R1 the same R1? Possibly not. Why? The hypothesis was, and is now confirmed, coming from the anatomy of the organ. I mean, the major vessel has a sort of external structure of the liver, are the skeleton separated that are separating different portions completely autonomously in terms of in and outflow each other. And then possibly the relationship between the tumor and the surrounding parenchyma is different from the relation between the same tumor with the border, with another part of the organ. The surrounding parenchyma is in the same place. The border is not in the same place. And indeed, we have to know that, and according to this approach, we started detaching. And this paper is showing recently for another, with another purpose, but is suggesting the rationale of the R1 vascular. Every vessel inside the liver, the major vessel, Glisonian and hepatic vein, other than the vessel wall and the Glisonian capsule, there is the Lennec capsule, as it is for the surface of the organ, and from the surface of the organ with the inferior vena cava. Then there is a structure that is further protecting the two structures, the vessel and the adjacent hepatic tissue, and in case of contact with the tumor. And then we could say that in reality, this contact could be not R1, but R1 vascular. And the first experience that we had, in which kind of patient, in what kind of patient? In the patient in whom there was a tumor in contact with the hepatic vein at the caval confluence, or in this portion of the liver, in between the first order and second order branch, right-sided, for whom, if we would have not accepted a detachment, we should have done a major hepatectomy. And this series of patients were patients in whom, even with the portal vein embolization, we would have not achieved enough volume. Then, to treat the patient, we accepted and we challenged their R1 vascular, and it was really encouraging. The first report that was released in Hepatogastroenterology in 2009. At the end, more recently, we had a larger series with an adequate median follow-up, and we share comparing the R0, R1 vascular, R1 parenchymal. And we showed that R1 vascular behave like the R0 in terms of local recurrence risk, better than R1 parenchymal, confirming the theory that was behind. And if we focus on the hepatic vein, which gave you more freedom degree, because for the hepatic vein you can also resect part of the vessel wall, while for the Glisonian not. And then here you have three solutions. Not only detach or cut the vessel, amputate the vessel, but detach or reconstruct the vessel. And indeed, we had, for those patients with colorectal liver mets at the caval confluence, 50% had the full detachment, 32% had the detachment with direct suture of reconstruction by direct suture, and just a minimal part had resection of the vessel wall with the patching. The other patient, to achieve the entire number, were had the compulsory amputation of the vein. Anyhow, for those R1 vascular, the recurrence was 6%, local recurrence. Then we can say that R1 vascular is an element that can stay in that formula with an adequate level of evidence in our perspective. And here we have a case with bilateral contact, right hepatic vein, middle hepatic vein, left hepatic vein, with several lesions here. We disclose that lesion which was behind the middle hepatic vein, and that lesion in contact with the confluence of the left. We look at the orange and yellow line, which is the transection line that we were planning on the liver cast preoperatively. The pink one were the disappeared lesion, a sort of, we named roller coaster hepatectomy. This is the real operation in this patient. Yellow, the dissection area as drawn on the liver with electrocautery, always in the confirming the attitude of the roller coaster. Then we detach the during the dissection. This is at the time of after chemo. You see that there was an important shrinkage. This is the CT before chemo, of course. with disappeared lesion after chemo. And the lesion was that one. We had taped the middle hepatic vein, skeletonized, removed a part of the vessel here, and then sutured directly and removed at the end also the lesion. And at the end, this is the roller coaster surgery with exposure of 3 hepatic veins. And this is the dissection path that we did for this patient. The other aspect is the CV, not the curriculum vitae, but is a communicating vein. Means communicating vein. Fortunately, I had no in mind any other acronyms. Well, if you cut the hepatic vein, normally, unless you have an inferior right, you should accept a major hepatectomy. But in spite of that, in our series, 28 patients and 30 hepatic veins were resected, and major hepatectomy were only 0.7%. And the reason why is not only the detachment, but in this case, once you have to sacrifice the vein, there is the ultrasound that helps you again. You can detect what is almost constantly present. Once you have a vein which is compressed and not detachable, you cannot reconstruct. When there is a compression, a slow growing compression in the time that tumor become larger, normally the liver adapt to the presence of this tumor and find out the shunting vein, communicating vein with the adjacent hepatic vein. Then you can, if you recognize the vein, respect the vein, you can just remove the vein infiltrated with the tumor and spare all the entire liver. This is a liver tunnel that was, the technique was published in Annals Surgery. Then take in your mind 2 concepts: detachment, communicating vein. You enhance the number of parenchymal splenic resection. In that series was the vast majority. In this way, we can think about coming back to the universe, that there is the dark matter, because you have the possibility to invent, if you take profit of this characteristic of the liver, you have an infinite kind of solution. All these procedures, those that have been described. And then we have changed, we are challenging this study, the classification of conventional one, trying to, measure the validity of our arguing about the kind of surgery that we are doing based on the outcome. And in that classification, for the first time, there were operations that were released by us. This is the upper transversal. This is in reality, this one is the mini upper transversal. And this one, in presence of the inferior right hepatic vein, was firstly described by Makushi in surgery, gynecology, and oncology in several years ago, more than 30 years ago. And this is the liver tunnel, and this is the limited with detachment. Could we reliably foresee the future liver remnant with such a complex dissection? Someone could say, yes, you spare the parenchyma, but anyhow you remove a lot of liver, and with such a complexity you cannot measure the remnant liver. It is not true. Nowadays, with the preoperative cast, we can foresee which should be the trajectory of our dissection, the expected one, and then we can foresee we could be the real future liver remnant, and this was the preoperative future liver remnant based on the cast, and you see the difference is quite minimal. This is another case in which we did with several contacts, a lot of liver removed. This was the real cast, and this was the preoperative one. Is it safe if we compare the results of the complex core hepatectomy, like the liver, the tunnel or the complex limited with the detachment. We referred as a standard reference to the right hepatectomy, which is the major hepatectomy that would have been done at least for the situation faced with these two kind of class of operation, where apart the bile leak, these two procedures offer more safety than the right hepatectomy. And nowadays we introduced the air leak test routinely, and even also the tunnel is not suffering anymore of such a minor anyhow complication. Is it reproducible? As I said, just teaching. The secret is just teach. The secret, of course, is learn and then after teach. This is the number of the operation that are done by my staff, and the mean age at that time, 31, then 36 years old, mean age. Now is 39, now in 2018. And as you see, the majority of the operation are run by them, not by me. And now is even more evident this act. And I may say that many surgeons, famous surgeons around the world now are convinced about this kind of surgery. And if we focus to the bilobar CLM, so if we focus to the condition in which has demanded the proposal of the stage procedure, no, exactly for this patient, for those patients that should be theoretically non-resectable. Well, this is our series up to January, so more than 1 year ago. So now is higher. Now we have 84 as maximum number of lesions removed. 8 was the median at the time, 10% major hepatectomy, so the vast minority. Most of major hepatectomy considered were left hepatectomy. Then we always spare the majority of the liver most of the time. Mortality was only 0.8%, 90 days. And you have to consider that bilateral were 1/3 contact of the patient, and those are formally not resectable, and 37% had more than 10 lesions. This is a patient with scattered lesion bilobarly. We use the navigation, then we compare the pre-chemo CT with the ultrasound that they move each other. And this was the resection. The secret is you have to identify the cluster of the lesion. If you can identify the cluster and you target the deepest one lesion in relation with the major vessel, you can build the resection area and carry out the resection. In this case, 83 lesions were removed. And you can, of course, afford the bilateral L1 vascular, those that should be considered unresectable by the oncological commonly accepted criteria. And this is the area of the detachment, P58, P67, and also the right hepatic vein, the middle hepatic vein, and the left hepatic vein. In this case, and this survival are, in considering that the bilateral are more disease than the other, anyhow, there was no difference at 5 years in between those with no significant difference. L1 vascular double, L1 vascular monolateral, and at 0. The disappeared lesion, which could be a problem if you use to spare the parenchyma. In this case, you see the scattered lesion of the pre-chemo cast. This is the pre-operative MRI. A few lesions are visible. We use the pre-chemo cast. Look, for clustering the lesion, we use the deepest one, targeting the one with adjacent to P58. And then we removed theoretically all the lesions. 32 of them were disappeared. salvageability. If you keep the skeleton of the organ, you can reoperate a patient. This was a patient with 12 lesions after a one stage hepatectomy. And you see the liver almost remain. I mean, you can recognize the skeleton of the organ despite there was a surgery, an extensive surgery in this patient already. The reoperation was obtained. We removed all the lesion. We did a left-sided liver tunnel exposing the left iliopsoas pedicle, the umbilical portion, segment 2 anyway was spared. We didn't do left lobectomy, middle aspirative vein exposed, and whatever. We want to spare whatever we could. And in case of the patient with only liver recurrence, 120 patients in that series, 60% were resected. Did the formula work versus other approach? Of course, we challenged the two-stage hepatectomy, and the criteria were dictated by the Paul Bruce group. We did this study with them, case match, Paul Bruce versus Humanitas. And of course, once at the same level of disease, more than 6 bilobar, more than 3 in the left, at least one more than 3 centimeters, more than 1 lesion in the contact with one, the first, second order, or hepatic vein cover confluence. These criteria were dictated by them because are the criteria that led them to do a two-stage hepatectomy. Well, we had no dropout, of course. And then on an intention to treat, there is an advantage of the single stage hepatectomy, R1 vascular. We were then challenged by the Alps Italian registry, and they couldn't collect a number of patients, which 12 center, which could be comparable with our in terms of complexity. Then we have to accept a matching of 1 to 2. And then it should be, it's of noteworthy the fact that those who run the Alps most of the time, many times, and I saw a lot of more lateral lesion in this series, they have to, they push too much this procedure. They pushed this procedure despite, as it has been proven in this paper, it could be operated within 1 stage. The mortality was lower, and be advised that we, in this 1.7, we include, unfortunately, all the 3 patients that we have lost in the entire series. Then our mortality is much lower than that. And the R1 0, of course, is in favor of the Alps, but in terms of survival, there was no difference. Then R1 vascular, 1 stage, treated more advanced disease with lower mortality and equal, not significantly different overall survival and recurrence-free survival, because we had accepted in our series the double vascular contact. They didn't, because they hadn't. Then at the end, and I move to the end, this is the patient that you show initially, for whom we were dreaming to do a parenchyma sparing. This is the parenchyma sparing procedure that we have done. Detachment, the tunnel here, and detachment here to remove the tumor, preserving Glisonian pedicle, 8 ventral, 1 and 2, and then preserve all this part of the organ that is drained by the middle hepatic vein, fully skeletonized. This operation has been sketched in our virtual cast has been used as the cover of the issue of February 2021 of British Journal of Surgery, in which and the patient that received this operation has been reoperated 1.5 years after the previous operation. And but we move further. I think that we are exploring something that has still to be disclosed. In this letter to British Journal of Surgery, I described it as the parenchyma-sparing vessel-guided major hepatectomy. That looks like a contradiction, a parenchyma-sparing and major hepatectomy, but in the fact, this is a major surgery done in a parenchyma-sparing way. In this way, you can face the high complexity and following always the vessel. The vessel drive you together, of course, with the good skill in ultrasound. I would like to invite all of you to join the live webinar in the advanced application of US guided liver surgery. It's the second edition. The first one was the basic one, and we will run that next month in a webinar, of course, free of charge. Thank you very much for your kind attention.
Thank you so much. Thank you so much, Dr. Torzilli. This was an amazing, inspiring, and I dare say provocating presentation. I have 1,000 questions. A lot of new things that you have done since the time I was there. But before I start my questions, I would like to invite our panelists, Dr. Nilesh Choradia and Dr. Praveen Kamar. Both are exceptional surgical oncologists working in several hospitals in Mumbai City with a keen interest in GI and hepatobiliary surgery. Take it away, Dr. Nilesh, Dr. Praveen. Any questions you want to ask Professor Torzilli?
Yeah. Thank you, Dr. Thank you so much, Dr. Torzilli, for this enlightening presentation. I have a couple of questions for you. In your practice, how often you do two-stage hepatectomies with or without portal vein dissection, embolization for colorectal liver metastasis? And do you think that eliminating second stage in two-stage hepatectomies, it increases inclusivity of patient, and does it impact survival?
I understood the first question, but not the second. The first question is how many times I do a stage procedure.
Yes.
Yeah. Yes.
Total number is 4%.
4%. Wow. Okay.
And the reason is when we cannot identify the cluster. I mean, when you have the lesion scattered all around the right-sided portal pedicle, without any portion that is free of tumor, then is 3600 degrees surrounding the tumor, you have to do a right hepatectomy. And then in this case, if you have the left side also involved, we are obliged to do the stage procedure. We have never done an ALPS in this sense. And I am confident I like the liver, the vein deprivation with the portal and the hepatic vein. I think this is, I think, a promising technique that we have not yet used because up to now we don't. But if there will be the chance, we will do that.
Oh, fantastic. Any other
question? I don't remember.
So I have another question. How do you manage recurrences in future liver remnant? Do you have timeline of in terms of some DFS or something, or any other benchmark?
How I mentioned, I manage.
So he's asking, how do you manage recurrences in the future liver remnant? You know, do you have a timeline as to when you would intervene within 6 months, 1 year, 1.5 years? What is the disease-free interval that you accept?
I mean, I can manage when the disease recur very early. It depends on the number of lesions that the patient has. If there is only one lesion or two lesions and is affordable with ablation, I suggest to ablate, and we are recently publishing a paper in this sense, to ablate, then doing the chemo. But if there are multiple lesions in a patient that will receive the one-stage procedure for multiple disease, we recommend again neoadjuvant chemo, and I mean, we do the same process that we did the first time.
Okay.
Unless the patient is refusing the chemo. Of course, if the patient refuses the chemo, although we suggest to do that, not to do that, or there are no other systemic solution, we anyhow proceed to surgery. Because we cannot forget that it's a question of survival probability. I mean, if you have an early recurrence, you have a lower prognosis for sure. But most of the time is not zero. And considering that the mortality of our surgery is less than 1%, the balance is in favor. I mean, you have to acknowledge the patient. Of course, anyhow, we recommend at first the systemic treatment.
Sir, I have read your article on humanitarian score for selection of patients for surgery. So can you please elaborate on that and how does it compare with ICG clearance test?
The humanitarian score is, I mean, take to put together the information that we use for selecting the patient for surgery, and are simple, except the fibroscan. I mean, the evoluted one, the rich one is the one that has accepted also the fibroscan. Initially, we proposed just the insertion of the cholinesterase to the bilirubin level and of course the volume estimation. And this was related to the fact that when I came back to Japan, I couldn't use the ICZ. I was the pupil. I am the pupil of Makuchi. Makuchi was the one that proposed the ICZ. So I wanted it. But I was working in a rural hospital. They don't want to buy the machine. So I had to arrange myself. And I found that it was working. Just with the bilirubin level and the volume, this was part of the flowchart of the Tokyo University. If you cut the lower part with the ICZ, there is the bilirubin level as a driver for resection together with the volume. Then I used that and it was working. I had a very low mortality. And I noticed that the cholinesterase played a good role. And the patient with low cholinesterase had a bad outcome. And I inserted also this. Then we published on World Journal of Surgery the first paper with the cholinesterase and the evolution. Once in humanities I became richer and I had the fibroscan. Of course, I wanted to measure the stiffness. When I was in Tokyo, we ran a study which was published in General Medical College of Surgery. I wrote the paper, but it was not my idea that I accepted the third name. It was a PhD thesis of the first author, but I couldn't be the first author. Anyhow, at that time, we were measuring the stiffness, and I was very interested in this procedure. And somehow the fibroscan and nowadays the elastography of the ultrasound machine can do that.
Thank you so much, Dr. Zili. Any questions, Praveen?
Sanket, sorry.
Yeah, Nilesh sir, go ahead.
Sanket, this is Ganesh here.
Yeah, hi Ganesh.
Hi. Yeah, could I just maybe a few questions? Prof. Torzili, absolutely brilliant work. Just a few questions for you. How often do you see bile leaks with this technique? What is your incidence of biliary leaks? Because
okay, we had 8% of bile leak, 12% in those with high complexity in the detachment of the Glisonian pedicle. Considering that, first of all, I have to mention that how we measure the bile leak. We keep the drain in the third, the fifth, and the seventh POD, and we measure the bilirubin level in the discharge. If it is above 10 milligram per deciliter, for us is a bile leak, even though it is not green or then not colored. Possibly this method let us monitoring very precisely the rate of bile leak because we measure routinely since I started. And nowadays we use the air leak test because more recently we had more like bile leaks because we pushed a lot our technique, and with that we are having very good results. Then I suggest not only the detachment but the bile leak test the hair leak test is a very good way of ruling out the tiny solutions.
Right. And as far as extrahepatic disease is concerned, we personally feel lung metastases are indolent. We go ahead. But what about para-aortic mets? Do you, if you say have para-aortic mets or multiple lung metastases, would you still go ahead? What is your approach?
No. For the para-aortic lymph nodes, tendentially, unless he's a young guy, very responsive and stable, we may challenge, but for particular situation, usually, tendentially, I do not push.
Right. And do you use the Myrian software, or you really have brilliant reconstruction? So what?
Fuji Synapse.
Okay. And do you do this for multicentric HCC as well in cirrhotics? Any experience?
We did in the past when there was not so many there were not so many alternatives, and I am not talking about sorafenib, but in a pioneeristic time, I mean 10 years ago, we have removed up to 30 lesions in a patient with
wow.
33 exactly. Was a young guy, but with chronic hepatitis, but not cirrhosis, and we were affording the heavy cirrhosis also. The mortality was around 2%, and nowadays not anymore, because we saw that more than 4 lesions larger than 6 centimeters, the outcome is similar to the arterial embolization. We published this paper, and there is another paper published by Chinese showing 5 or 7, but quite similar. And then we stopped to operate a lot of tumor in the case of ACC. We restricted our.
Right. Just one last question. So there are times when you have a non-responder to chemotherapy, or somebody who progresses on chemotherapy, which obviously is a bad prognostic sign. So would you still go ahead with operating them, or would you shy away?
This is at first there is no evidence in literature that chemo for sorry, I have to stop the printer because my daughter is continuously printing behind me something. She doesn't realize that I am in a webinar. Sorry. And then what I was saying, yes, when there is no paper that shows that there is an advantage to do neoadjuvant chemo in patients with multiple bilobar. The only one that was showing the role of neoadjuvant chemo for a maximum 3 lesions was the one published on Lancet and whatever by AORTC, and failed to prove a benefit in overall survival, just in progression-free survival, which is an oncological measure, not a surgical one. We want to see the patient surviving. We do not care if the one at 1 month ahead, the relapse, or 2 months later. But if they survive equally, and then there is not such evidence. But I agree that nowadays is reasonable to do the chemo before. And there is the oncological community that is too strong, then you cannot try to. Indeed, now, if we are doing a comparison historical inside our own series, and the results is surprising. There is no different survival in the pre-chemo, in the chemo era. So it should be, but it will be, of course, rejected everywhere because methodologically it's not a randomized trial. And anyhow, to say briefly, if a patient have no chance to be treated with systemic treatment because there are no chemo. He has done 3 lines and whatever, and is still resectable, in good shape and young, we afford surgery.
Right. Thanks. I think that's great. And just to so just since you had a study where you compared with Rene Adam's group head to head with the 2-stage hepatectomies, was there a difference in overall survival or disease-free survival between your 2 groups, or obviously you would have resected much more, but the disease biology would obviously dictate the overall survival. So just wondering, what was the difference?
No, there is another paper that we, with the same series, but the matching was different because the target was published on European Journal of Surgical Oncology. I forget to insert the slide, in which we want to see what we were saying. We operate all the patient that you operate with a different approach, single operation. You said that with the 2-stage procedure, you select the best patient because those who drop out are those patients who do not deserve surgery theoretically. But if it is so, operating in a single operation, we operate also that patient. Then we should expect our series a worse recurrence-free survival.
That's
and
right.
Not the case. We did the comparison and the curve are exactly the same. So there is no selection. To us, is a loss of chance, not a selection.
Yeah, I think that's a fantastic point. We are in 2-stage surgery. We are not offering surgery to nearly 30% of the patients, if I'm not wrong, which is lost opportunity for those patients. In the same vein, I would like to ask you, so, since we're talking about extrahepatic metastasis, you do have a paper with Dominic Elias where you looked at colorectal liver metastasis and peritoneal metastasis. So how do you select those patients? What is the strategy in your institute to select patients for a combined approach? Or do you do a 2-stage where you do the liver first approach? Or how do you approach your patient who has got colorectal liver metastasis and peritoneal metastasis?
It depends on the degree of the involvement of the peritoneum. If it is a local, we proceed. If not, and as a multiple bilobar, it is very difficult to achieve the window to offer surgery to the patient because the 2 kind of approach is completely the opposite. If you want to do the IPEC and the peritonectomy, you need to fill the patient with the liquid. For us, it's like killing the patient because if you divide the liver with full of water, you lose the entire amount of blood of the hospital you have to use. Then I think we did so with a few lesions with the not so difficult procedure we have done, but for advanced disease.
Okay, I have a few questions. Let me start with it. The first thing, it was an extremely enlightening presentation, Professor. Thank you very much for that. And I had a couple of questions regarding a neoadjuvant chemotherapy before the liver-directed surgery. So, which is the commonest chemotherapy regime is used in your center? And is there any specific choice? How many number of cycles you use before evaluation, and how do you go about it?
About the neoadjuvant, I let the oncologist select. Although I just recommend them to use the strong one, and we do not recommend 6. I mean, better for us is 4 cycles because if you consider resectable a patient, you don't need and you don't want the disappearance and you don't need the extreme shrinkage. You just need to know the biology of the disease. And this is difficult to convince the oncologists that they want to do the more chemo, the best is, but it's not like this. Of course, after the patient will finish the line, but for me, 4 courses.
So, sir, if you have a primary, resectable primary with, say, 3 separate lesions in the liver in 3 different segments, would you go for chemotherapy first, or would you prefer surgery? I mean, personally, I know the medical oncologist would probably
Personally, surgery.
surgery.
There is no proof that is, you described exactly the case that were published to show that neoadjuvant surgery is better than surgery up front, and they failed to prove. So up to 3 lesions, of course, if, what I have to consider is also the environment and the family and the kind of oncologist the patient is addressed to. If they are true aggressive, the patient is disoriented and whatever, I don't want to make a war with the oncologist, within the middle, the patient.
Yeah.
And because at the end, the result is that if there is a relapse, they will say, because you didn't do the chemo, then this is the fault of the surgeon and whatever. And if there is an agreement, I proceed with surgery. But if not, okay, do chemo and 3 cases.
So another question, Professor, how many resections, your presentations of colorectal liver metastasis you say in synchronous setting, with the primary in situ and presenting with liver metastasis, and how many metachronous presentations in your practice?
Well, synchronous are the majority, but synchronous means those patients with the mets within 6 months from the primary. About the approach with we operate nowadays also one stage with aggressive disease. We did 2 cases last week of 20 and 25 lesion, and right hemicolectomy. For the right-sided colon, we do that. But especially if there is a symptomatic disease.
And one more question is about the adjuvant chemotherapy. So does the type of resection, whether it was completely R0 or R plus vascular resection, does it have any bearing on how do you go about the adjuvant chemotherapy you advise for the patient?
For me, every patient should receive the adjuvant. Otherwise, they throw away the chance of that line. They have to conclude and maximize the results of the line that they initiated before surgery. So normally the neoadjuvant is 4 to 6, then they have to do other 8 to 6 cycles.
Yeah, and one final question is about, I read in several of your papers how you have defined the post-operative liver failure. So I was wondering, like, whether your definition and the approach to the management of liver failure has changed over a period of time, the post-operative liver failure.
Well, the definition is always based on the categorization of the bilirubin level 5, below 5, 5 to 10, and more than 10. And we use the expertise that we had for the cirrhotic patients, and generally we monitor the curve of the bilirubin level. We support the patient with plasma, fresh frozen plasma, and we keep the drain if the patient has ascites, and monitoring the curve of the decrement. Normally, it increases after the 5th postoperative day. For the 2nd week, of course, the patient has a longer hospital stay. I may say that we didn't find so many cases of severe liver failure. In the recent year, I do not remember one, unless the patient that died for complication, very few, but died for complication in terms of vascular complication of the liver, not liver failure or insufficient volume.
We have one question from the audience. How often have you needed second and third resections for recurrences after your approach?
Oh, sorry?
How often have you needed second and third resections after your approach? We have this question from Dr. Himakodia.
We arrived up to, as I saw, the liver-only recurrence, we had 60-70% of the patients we operated. The maximum number of the operation is 5. Just 2 days, today is Saturday, yes. Thursday, we operate a patient for the 4th time.
Any questions by Dr. Saklani, Dr. Shivendra Singh, Dr. Aditi? They're all on the panel.
For those.
Hi, Sanket. I just want to ask him about conflict. So suppose if you have a solitary lesion and the intervention radiologist wants to do an RFA, and which is of course resectable. So how do they resolve conflict for resectable but RFA lesions, small lesions 1.5 to centimeters? If the intervention radiologist wants to do RFA or cryo.
I accept the RFA. Below 2 centimeters, if it is not superficial and not in contact with the vessel, I think that is reasonable, because the rate of local recurrence is almost 0.
Okay.
Especially in the post-operative course after surgery, in this, when they have 1 single or 2 lesions, we push for the RFA.
I have one more question, Professor. In one of your slides, you showed how you combined the pre-chemotherapy images of the liver with post-chemotherapy images of the liver. Is there any software, or your radiologist, how does it do it?
We use Synapse.
No, yes, we use Synapse as
okay.
We use Synapse, but we use also in the ultrasound machine, you have the fusion imaging. Then we upload the pre-chemo imaging, and we match in real time with the ultrasound exploration, the intraoperative ultrasound. You see in the screen one thing. I must say, to be honest, that the synchronization of the image is frustrating because it's not working enough. But I now use the habit to use the ultrasound to move the CT. Then I recognize the position of the target lesion that I want to target to draw my cluster, and then I go back to ultrasound with the same machine. So you do not need such a sophisticated technology, but this can be useful.
And Professor, in one of your papers, actually, you had mentioned about using ICG for segmental resections and the reverse staining as well. So how often you use it in your surgeries nowadays?
We use every time that we have, especially for the ACC, we use that when you do the compression technique. We compress the pedicle. And sometimes the discoloration is faint, is not so evident. And nowadays with the ICZ, the rest of the liver become green, and the segment is well disclosed, just compressed. And in case of thrombosis of the segment, we use to clamp the artery, hepatic artery at the hilum, and inject the ICZ. There is the thrombosis. Then you see the segment that remains with the thrombosis that remains completely discolored, while the other part of the liver become fluorescent. Then you can disclose nicely the resection area. But nowadays the fluorescent is used in various ways, so I may say that the originality is not so. It's nice. Laparoscopy. Nobody has asked me anything about laparoscopy. It's strange.
That was my next question, Professor, actually. What is the proportion of laparoscopic liver resections that happen in your center?
The proportion of laparoscopic liver resection in our institution is around 20-25%. You have to consider the case mix. We have, nowadays we have done some one stage by laparoscopy, but 5-6 lesion. It's funny because 5-6 lesion for us is nothing. But no, not say, no, it's not just to show but it's the average number of lesion of the laparoscopic paper about the stage procedure. Then I would like to say one thing. And now I saw a paper of smart Alps. And most of the patients had unilateral disease. Then some laparoscopists are reintroducing the concept of the major hepatectomy, especially in the western side of the world, done by laparoscopy for cases that normally in open surgery receive always, even by non-expert surgeon in parenchyma sparing, a parenchyma sparing approach. I think that this is almost unethical. You cannot do 2 operations selling them as a laparoscopic fantastic procedure if you can do easily a single operation for the same disease. But this is the world in which we are now.
I remember you saying this, that right, we are moving towards maximally invasive surgery by minimal access approach and not minimal invasive surgery.
You said. Yes, this is what we said is a max. What we show today, we discuss about is a maximally invasive with minimal sacrifice of the organ. But while nowadays the attitude is the mini-invasive to be maximally invasive inside. And this should be explained to the patient, because the patient just look at the picture of himself with the swimsuit. But if you have inside 1/3 of your liver, I would not be so happy.
So I think for lack of time, okay,
one last question. Yeah. So Professor, for something like a rectal primary, who is like a case which is ideal enough for a minimal access rectal cancer surgery along with liver metastasis, and if in case he requires a diversion stoma, does it affect your thinking about going ahead? Like, how do you manage the liver and the rectal primary?
What you said about
rectal cancer,
rectal surgery, liver surgery.
Yeah,
we have done some multiple resection during the low anterior resection of the rectum done by laparoscopy. I think is a nice way of operating. It depends on the question is, can I offer to the patient the same approach that I would offer in open surgery? Yes, it's okay. But should be really like this. And since in the liver, the clue is in the liver, the concept of resectability is a concept that is not really shared. It depends on the surgeon. Then the sentence, you should do what you should do in the open, also in the minimal invasive. But if someone is not able, then, he would like to do a right hepatectomy for a tiny lesion in the open, he can say, okay, I will do also a lap. And in this way, with such elasticity, it is easy for many colleagues to push crazy operation done with the minimal invasive procedure. Alps, vein deprivation, and major hepatectomy together in 2 operations. Not 3 lesions, 6 lesions, 1 lesion.
So in the interest of time, we'll stop the question and answer session. And if everybody is comfortable, we can go for a case presentation.
Yeah, sure, Dr. Sanket. I think
Yeah.
we should move ahead.
Sure.
Praveen, River Route, can you put on the next slide, please? So this is a 65-year-old female who presented with pain in the right iliac fossa and decreased appetite and weight loss, along with weakness of the anterior compartment of the thigh, along with pain. The tumor markers were sky high with a CA19-9 of 9,000 and a CEA which was 544. And a CT scan which revealed a large mucinous tumor in the right iliac fossa involving the psoas muscle along with the femoral nerve and multiple hepatic metastasis. An OGD and a colonoscopy were normal. Next slide, please. So this is the CT scan. Can you play the video? So as you can see, there were 16 lesions in the liver, 15 on the right side and one in segment 3 of the liver. As we go down, we'll see the other lesion that was there in the abdominal cavity. So this is the lesion which is abutting the colon and what looks like probably involving the right side ovary along with the psoas muscle all the way up to the iliac crest bone without involvement of the bone. And this lesion is pushing the common iliac vessels. Next slide. The biopsy of this lesion was adenocarcinoma. The tumor, the immunohistochemistry was non-contributory, so the pathologist suggests that it can either be a GI or a mixed or a Mullerian origin. In view of the high CA19-9, we had also done an MRCP, and the MRCP was not showing any lesion in the pancreas. And the PET scan was also not showing any other primary lesion. Next slide. So we included this case in a multidisciplinary team meeting, and we decided that we would consider this an appendicular primary with multiple liver metastasis, and he was started on a GI-based treatment with Capox with bevacizumab. She received 6 cycles of chemotherapy. It was not by choice. We wanted to evaluate earlier, but because of the lockdown and because of lack of family support, as her son was living in US and he could not come back because of the lockdown. So we had to give her 6 cycles of chemotherapy, after which she was re-evaluated with the tumor markers nearly normalizing, CEA of 5.9 and CA19-9 of 148. And the PET scan showed a decrease in the size of the mass as well as the size and number as well as activity of the liver lesions. The next slide, please. And this is the scan. Can you play the video? I'm sorry, they're logged out. Can you play the video? Yeah. The lesion is markedly decreased, partly calcified, and there were, I think, 7 residual lesions in the liver. So, Dr. Torzilli, how would you approach this case? What would be your thought process?
I try to remove everything. The problem is the disappear lesion.
Yes. And would you consider synchronous surgery for the primary tumor as well as the liver?
Synchronous surgery, if it is, I mean, I saw that the patient was resectable. Then there are 2 lesions deep
Yeah. So as you normally approach, the target lesion was at the segment 5-8 bifurcation.
But anyhow, I think that the cluster can be identified. I mean, a resection that shift from a right hepatectomy to something that can be more conservative is suitable. They have only one lesion on the left. And I think is also resectable the disease in the right iliac fossa with a right hemicolectomy, and of course sacrifice, resection of the muscle, limited resection of the portion which is infiltrating the muscles in contact with the bone. I should consider the two operation in case intraoperatively would not be the case because you find more difficulty. At this point, I would clean the liver and then do a second operation with the.
Yeah, so that was my next question. Would you approach the liver first or the pancreatic first? So answer the liver first. Okay, next slide. So this is what we performed, kind of a upper transversal hepatectomy with segment 3 resection, along with resection of the primary tumor all the way up to the iliac bone, removing the psoas muscle, the femoral nerve, as well as the periosteum of the iliac crest, and salping oophorectomy with right hemicolectomy. The patient had an uneventful postoperative course and stayed in the hospital for 13 days. Next slide, please. The final histopathology was showing 11 lesions in the liver. All nodes submitted were negative, and the colon, the appendix, everything was not showing any tumor. The tumor deposit in the muscle was again moderately differentiated adenocarcinoma, and all margins were negative. And in the immunohistochemistry was again not very contributory, and in the absence of any tumor in the appendix, they have suggested it might still be in the pancreatobiliary, the primary might be in the pancreatobiliary tree. Next slide. In the post-operative period, 6 weeks after surgery, her CA19-9 was 145. Before the surgery, it was 154. So in a scan was normal, was not showing any disease. So we decided to keep, in a multidisciplinary team, we decided to keep her on oral capecitabine as maintenance. What would you do, Professor Torzilli? What would be your approach in this situation?
We'll come back in the previous slide.
Previous slide, please.
Then the second is pancreatobiliary. And then the next.
Next slide.
Yes.
So post-operatively, her CA19-9 level was still slightly on the higher side. So we put her on oral capecitabine. She's been on oral capecitabine for 6 months, and now the CA19-9 is 54. A scan done last month, PET scan, does not show any recurrence of disease.
Yeah, I should do MRI, though.
Yeah, MRI. Okay. And what next? Suppose if there is still no disease.
If you don't see any target, just strict follow-up.
Okay. And would you continue any chemotherapy or?
Well, how many cycles of capecitabine you did?
It's now 6 months more of capecitabine.
I would stop.
Yeah. Any member in the panelists would have a different approach? Ganesh.
So I have it's not about the approach. I think it's that's great. The only two questions, and one is that, so obviously there is this issue of disappearing metastasis, and just wanted to find out from Prof if you do use a contrast enhanced ultrasound, and have you found any improvement in your pickup rate, or intraoperatively, do you ever use that to look at especially the disappearing liver metastasis?
Question is to me.
Yes.
Yes, Prof.
We use the contrast enhanced ultrasound, especially when we have isoechoic lesion and also disappeared one. I must say that for the disappeared is not so effective. At least the sonoview. I think that with the Sonozoid, the one that still has only the Japanese since 15 years almost. I don't know why, the reason why, but anyhow is this. This is an hepatospecific contrast, and then you have around 20 minutes, 30 minutes in which the effect of the contrast remain, and it may be suitable. And they have a nice experience in which they show that if the patient has MRI negative and contrast enhanced intraoperative ultrasound with Sonozoid negative, possibly there is a high probability that the lesion disappeared or really disappeared. Up to now, we have not such a facility, but then with the vascular contrast only, the effect, especially in a diseased liver in which the parenchymatous phase is not so nice, it is very difficult to identify if there is something that is not visible with the basic ultrasound.
Right. So you said that you kind of sync the pre-chemo imaging along with your ultrasound, your intraoperative ultrasound. So, would you remove the corresponding area of the liver where the lesion was previously and which is now supposedly disappeared?
Yes, exactly.
You would do that.
We take a profit of the anatomy of the organ, and always, if you put in relationship with the vessel, you exactly target the area that which you would like to remove.
Right.
Possibly the artificial intelligence will help us in this sense. If they have the ability not only to do the liver cast, but also to disclose you even the criteria, the dissection line to do this kind of surgery. This is
Shivendra, good to see you finally on the screen. Any questions, any comments from your side?
I think it was a good case, but I also wanted to know whether to get a good R0 resection on the iliac side, whether there was because the margin, whether
so
a good margin.
The periosteum was free. We resected the periosteum as the margin, and the periosteum was free. So I guess that was.
So Sanket, that was so finally that the deposit was probably a peritoneal deposit, right?
Yeah, looks like, or soft tissue deposit. It was involving the psoas muscle. The peritoneum was not involved.
Did you consider HIPEC?
No. As I said, HIPEC and liver resection don't go very well together. And
okay, that's great.
So I'm afraid we're running out of time, and I think we will have to conclude. It was such a wonderful session. Thank you so much, Dr. Torzilli, for spending so much time with us. I'm sure everybody enjoyed, and it will be an immense help for all of us who have attended this session. Please note down the date. It's 23rd June, where Professor is having another online session, which you can register for. And Dr. Torzilli, I would like to end with concluding remarks from you. Anything you want to say to us?
I would like at first to congratulate you for this fantastic initiative and for the great operation. It was very nice. And really, I'm really pleased to see that. And I also would like to say hello to Shivendra that I see now. And I really congratulate all the community of the people that was joining this session, because I really enjoyed a lot. Thank you very much to all of you.
Thank you so much, sir.
Thank you so much. Thank you.
Thank you, Professor Guido, and thank you, Dr. Sanket, for this wonderful discussion. So now I invite Mr. Lakshay Basi, Product Manager, Surgical Stapling and Devices, Medtronic, to present on GenNext stapling technology. Over to you, Mr. Lakshay.
Thank you. Thank you. Hope I'm audible.
Yes, sir.
All right, great. I'm just sharing my screen. Okay, thank you. I'll just try to keep it short. I know it's a bit late in India, and thank you very much to all the delegates. Let me quickly go to my first slide. Okay, so Medtronic has had a very rich history, as you can see in stapling products right from 1990 and onwards. So I mean, in 2011, we launched the world's first powered stapler, which was the iDrive, which was launched in 2012, and later on, the legacy continued with other generations of tri-staple reloads, with the radial reloads as well as with the purple reloads and the buttress material, which was launched in 2014. And 2017 was special because we launched Signia, which is world's first smart stapler, which I will cover today. So this is Signia, and it comes with actually three adapters, and it's actually smart. So when we say smart, it actually senses the tissue, and then it uses its adaptive firing technology to decide how fast or how slow it should fire. So the firing will depend upon the tissue thickness. It can even slow down in between when it encounters a thicker tissue. So in short, it actually helps in ensuring that there is optimal staple formation. Now, this zones that you see out here, 1, 2, and 3, these are the zones that you will see on Signia while firing. Now, globally, we have come up with a new software version for the existing Signia users, where this feedback can also be seen on our tri-staple legacy reloads. Now, this is Signia, which actually comes with powered rotation, articulation, firing, jaw opening, and jaw closing. So everything is powered. There's nothing which is battery operated. And it comes with smart tissue sensing and adaptive firing technology, as I discussed, which basically decides how fast or how slow I should go. These are the different zones in which actually fires. If it encounters a thicker tissue, it will slow down its speed and it will fire in zone 3. It will show you on the screen that I'm going to fire in which particular zone. Now I absolutely love it because Signia comes with full 300 cases. So when we say 300 cases, it's absolutely 300 different patients. So you just have to pick the Signia from its rechargeable, the charger. But the beauty of the Signia is that it is rechargeable. So just like our cordless phones at our house, it can be placed on a smart charger, and the charger will charge Signia in about 3 hours, and then you can continuously use it for about 18 hours. You can use it for 300 cases. That's its limit of the handle. Talking about the firings would be, about 3,000. So that's not a problem there. Okay, so as I said, it comes with real-time feedback on the OLED screen, so you can actually know which zone it is firing in, what is the reload that you have attached, where have you fired the reload, at which stage it is, whether it's at 15 mm, 30 mm, or 60 mm. So it will tell you on the screen itself. Now, the best part is universal reload attachment capability. So more than 50 reloads can be attached with Signia. So any color, any shape, any size, tri-staple or non-tri-staple, everything can be attached. So that's the beauty of this device. Now, this was the stapling part. The gun or the stapler or the smart stapler. Now, coming to the central technology, which is the tri-staple. Now, tri-staple basically has 3 different staggered rows of staples in it, which includes the inner one, which is the smallest, and going towards the outer one, that's the highest one. Now, it ensures there's less stress on the tissues, and it ensures there is a greater perfusion into the tissues, and the performance has been seen as really better in terms of variable tissue thickness. Now, it comes in all the different shapes and specialties. It comes in the linear one, which is the classical tan or the purple, but also comes in the radial, which is good for ultra low LARs. It comes with the curved tip as well, which is very much useful in tight spaces and harvesting those vessels and ducts. Then there's black for extra thick. This is the thickest. The outermost there is of the staple is 5 mm. And then there's also very slimmer profile of 30 mm reloads. Then there's buttress material, good for hypertensive and obese patients. Now, innovation doesn't stop here. Globally, this tri-staple family also reached our open stapling range, and in India, we recently launched this circular stapler, which comes with tri-staple, 50% higher staples than any other circular stapler in the market. 3-row tri-staple circular stapler with actually maximum security. So the classical ones would come with, let's say, 36 staples. This one will come with 49 staples. So actually 50% more. If the classical comes with 28 staples, it will come with 42 staples. So that's the difference. Now, apart from the security, it ensures 44% fewer leaks as compared to Ethicon Serial staplers, 63% more security to the staple line. The audible feedback is very loud, and the force required for firing is very, very low as compared to before. So there's a 62% reduction in firing force as compared to before. That's it. I wanted to share these couple of inventions of Medtronic into the world of laparoscopic as open stapling. You can reach me on this phone number and on this email ID. Thank you very much. Over to the next presenter.
Thank you, Mr. Lakshay. So now I invite Dr. Praveen Kamar to give the concluding remarks, sir. Over to you, Dr. Praveen.
Thank you, Praveen. I would like to thank Professor Dorzilli for an excellent presentation, which was very thought-provoking, inspiring, and enlightening. I'm sure all the attendees would have will be going back to the practice with new knowledge about colorectal liver metastasis and the upcoming and the established treatment parameters. And this is the first of our masterclass series, and we are extremely happy to have such a fantastic response, and we were not expecting this much considering the situation in the country. And I would like to extend my sincere thanks to all the attendees who have made this a grand success. And I would also like to thank the team of Medtronic and Mr. Lakshay for the excellent presentation and the support they have extended to make this program a possibility and a success. And last but not least, the team of River Route, who single-handedly organized the software part of the whole thing. And with that, I would like to conclude my remarks. Thank you very much, everyone. And we would look forward to have you again for the next session of our masterclass.
Hello.
Thank you, sir. Thank you so much.